If people have pain in the prostate, they often feel that they've got something stuck up their bottom. That's sometimes what I see, but more commonly we describe it now as chronic pelvic pain. So pain coming from any of the organs in the pelvis, whether it's the prostate, the perineum, the testicles, the bladder, or the penis, or even the groin. Unpleasant sensations, painful sensations, which cause people bother. This is often what patients will describe, and the pain can either arise from these organs and from these parts of the body, or it can be what we call referred pain. So it means the problem may be somewhere else, but the brain is unable to distinguish that location from where they feel the pain. The site of the pain is often useful to know and requires investigation, but also we do a more comprehensive, broader assessment in order to check that there's not pain or a problem somewhere else causing pain in the pelvis or in the prostate. The things to look out for, obviously if you do have pain in any of the pelvic organs, pain in the bladder, pain in the prostate, it's worth having a discussion with your GP. But also other symptoms that we do get concerned about and we think should be investigated are things like blood in the urine, either that you see or appears on a urine test. Could be blood in the semen, changes to urinary symptoms or urinary infections, or even things like erectile dysfunction, which affect a lot of men and can be a sign that something isn't quite right underneath. There's no single test for prostate cancer, but we can help men to understand their risk by taking a bit of history about the history of prostate cancer in their family, their ethnicity, other health issues, and then starting to talk about things like a PSA test, which is a blood test called prostate-specific antigen, which is not a test for prostate cancer, but it can help to understand someone's risk. The prostate examination is less commonly done now, and there's some evidence it doesn't add much to the assessment of someone's risk for prostate cancer, but it can be useful for understanding the size of the prostate, or if patients have prostate pain. Prostate cancer cannot really be diagnosed on any single test reliably. So it's about undertaking various different assessments, in a sensible and systematic way to build up a picture of someone's risk. First thing is having a conversation, asking questions and hearing about someone's life. From there, the next test is generally a PSA blood test and perhaps a urine test. We can then go on to MRI scan, and then if this combination of tests and the patient's history point to someone who is at a significant risk of prostate cancer, we can offer patients a biopsy, which actually is able to either confirm or refute the diagnosis. Much of this nowadays we classify as low-risk prostate cancer. Actually, the recommendation for this is just a monitor. Some men may need additional tests if they're thought to be at higher risk, and that's to accurately check where the cancer is to make sure we can recommend the correct treatment. In my experience, there's usually not a best treatment for patients, but there are options, and we help patients to work through those options to really tailor their management plan according to their own priorities